Hi, everyone. Welcome to our October ICARE Genetics Case Conference. I'm Tua Pal, and I'll go through a few housekeeping slides, after which we are really excited about our guest expert, and we'll go through some cases. So just a highlight for our schedule for next year remains the second Thursday of the month, unless there's a conflict with another meeting, but we are moving up the time by 30 minutes. So it will be 11 to 12 Central Time, 12 to 1 Eastern Time, and we have the dates here outlined. And then we have some really exciting case conferences with guest speakers secured over the next several months. So again, for those that are interested, please check it out. We're also grateful to all of our ICARE partners for referring your high-risk patients to our registry. In addition to that, what I would also encourage folks to do is submit interesting cases. So again, we have many in our own practice, but we really do want to use this as a forum to share the expertise and to provide feedback as needed to others as well. So try to make it as easy as possible to submit the cases. It can be through a REDCap. We'll help you make the slides, etc. And then, as many of you know, we have some resources available. We have our case conference that's right now. We have a biannual newsletter that we publish every 6 months or so. Our website is searchable. So again, the information we have in our newsletters and our social media are searchable on our website. And then we are active on social media with new information, including talks, newsletters, open studies, stories, research updates, and guideline updates. And the handle is @inherited-cancer at the social media platform of your choice. Looking at ICARE focused efforts, we're still conducting our genomic characterization of inherited breast cancers study and have some exciting results. This is being co-led by my colleague Sonia Reed. So we thank our colleagues, our ICARE partners, for referring your carriers to us, so the ICARE has functioned as our recruitment tool for this study. I also wanted to let folks know that our October newsletter was just released at the beginning of this month. It's again available at the link to anyone that is interested. And then just to highlight some of the updates included, we have the updates again summarized for both the genetics panels, the breast, ovarian, pancreatic, prostate panel, as well as the colorectal, endometrial, and gastric cancer panel through NCCN. Again, I wouldn't say it is a comprehensive look, but it's some of the highlights that are included in the guidelines. And then we have several articles focused on cancer risk refinement, as well as treatment advances. And then thematically, we use this as an opportunity to highlight cascade testing. So we have an Ask the Expert question that my colleague, Dr. Brian Schertz, answered, and he is the founder of the not-for-profit Connect My Variant. So again, we're excited to have Brian comment on some of these issues regarding cascade testing. And then we have my other colleague, Kathy Baker, who is the founder of the not-for-profit My Faulty Gene, talk about her experiences with having the mutation, being both a breast and ovarian cancer survivor and being a disseminator of information across her family, as well as developing additional tools for family sharing, including Family Gene Share, a website with patient testimonials that really is phenomenal. So again, we were excited to have Kathy as our spotlight, and then going through some additional research efforts and resources are included. I also wanted to highlight that we have, through NCCN, for the genetic familial breast, ovarian, pancreatic, prostate guidelines, this guideline navigator. So when you go onto the NCCN website, which all of you know requires a free username and password, on the right side, you could click on the guidelines if you wanted, but there's this guideline navigator, which is an interactive tool. I was playing around a little bit with it, but there could be instances where this would be helpful if you're trying to get to whether someone is eligible or what would be the adequate risk management for someone. So again, I would encourage folks to check it out. It is now available for the genetics familial high risk breast, ovarian, pancreatic, prostate guidelines. And then really excited to announce that our ACMG practice resource that we've been working on probably over the last 12 months, maybe longer, that was co-led by our guest expert, Dr. Helen Hanson, as well as our other colleague, Dr. Joanne Nguyen, was just published a couple of days ago. Here's a link to it. And it's focused on the management of individuals with mutations in RAD51C, RAD51D, and BRIP1, and much of which Helen will kind of provide us an overview with during her presentation. So with that, I'm going to hand it over to Brenda to set the stage for a real case that Helen can then comment on, and we can take it from there.
Thank you. All right, so this is, I recently saw this patient. She's a 42-year-old female. She has had normal yearly mammogram screenings, intact uterus and ovaries, and a history of 5 cycles of IVF unsuccessfully, having been pregnant, and she still has 1 remaining embryo. Her family history includes mom with breast cancer in her 50s, maternal grandfather with colon cancer in his 80s, and then no other cancer in maternal aunts or any of her cousins. And then dad had esophageal cancer. Paternal aunt had triple negative. No, not this one. That's the other one. Paternal aunt had breast cancer at 54, and she had negative BRCA1 and 2 testing in 2013. I did look at her report, and she did not have a panel. She only had BRCA1 and 2. And then the grandmother had breast cancer in her 40s. She has 1 adopted son. And so we did a multi-gene panel, and she has a BRIP1 mutation, a pathogenic variant. So unexpected based on family history. And so just a brief overview, the breast cancer risks for BRIP1 mutation carriers, and there is insufficient data to really define if there is a risk. Ovarian cancer risk is 5 to 15%. And then the recommendations, breast cancer to manage based on family history, and then to recommend risk reducing salpingo-oophorectomy between 45 and 50. But I do think what's interesting is in NCCN, they also have a comment that says current evidence is insufficient to make firm recommendation as to optimal age for risk reducing salpingo-oophorectomy. So the conversation should be had between 45 and 50. So the interpretation of this is it was a little tricky for me because it says recommend, but then it says that there is insufficient evidence to make a firm recommendation. So anyway, we talked about recommending testing for her parents first to see who is the carrier, and then informed cascade testing, but also wrote a family letter that she can share with her family members. And I'm not gonna, this talk is not about this specifically, but we spent a big chunk of our time discussing autosomal recessive Fanconi anemia, and then considerations for testing the remaining embryo because she still has hope that she can use that embryo. So we talked about testing the husband if she's concerned about Fanconi anemia. And so just a lot of stuff came up about, does she want to test the embryo for the BRIP1 mutation? And she was like, well, what if I test to see if the embryo is a female? And if she's a female, then we can do BRIP1 testing. So she kind of went down this rabbit hole, brought up a lot of emotions. So yeah, it was an interesting conversation with her. And it was really sad because it brought up the feelings of not being able to conceive a biological child and now being afraid that her embryo may be a carrier of a BRIP1 mutation and possibly Fanconi anemia. But what I wanted to present on are the cancer risks. So I ran CanRisk on her, and her breast cancer risk, lifetime risk, was 25.4%, which is based on family history. And so she is considered high risk and was referred to the high risk breast clinic here at Vanderbilt. But then her ovarian cancer risk, she's relatively young, and her lifetime risk was 4%, which is below that threshold that's provided by NCCN. So I thought that was interesting that her risk was a little bit on the lower end. Granted, there is no family history of ovarian cancer that we know of. And this I pretty much already went over. I referred her to gynecologic oncology to discuss, to establish care and discuss the risk-reducing bilateral sublingual oophorectomy. She was referred to the high-risk breast clinic. We talked about testing her family members, referred her to ICARE, and then that Connect My variant as well, that Dr. Brian Schertz leads. And so I just want to get your thoughts on that ovarian cancer risk, Dr. Hanson.
Yeah, thank you, Brenda. It's a really interesting case. So so I suppose in considering the absence of family history of ovarian cancer, it's probably not surprising that the risk is at that lower threshold. We know that there's a range of risk and there is an impact on family history. So there will be some BRIP1 and also RAD51C and D carriers who would probably come at that lower end of risk. I've got actually a nice chart in the presentation that shows that threshold. So I think if you're looking at 5% at a greater than 3 to 4% risk, then all BRIP1, RAD51C and D carriers probably come above that 3 to 4% risk hold, but if 5%, some sort of straddle that. There is also another paper that I'll mention in the talk from Cummings et al., who looked specifically at people who have been tested and found to be carriers through multi-gene panel testing, and they found that the sort of median age of onset for BRIP1 carriers was of ovarian cancer was 65, and with an interquartile range of 58 to 72. So actually, although the recommendation is for sort of consideration at 45 to 50, I do wonder with her if you could be a bit more, permissive, and suggest that maybe, over the age of 50 might be more appropriate for her, given that there's no family history and how this has been ascertained. So I think that would be my comment, is that it is a low risk, and I think it is because there's no relevant family history of ovarian.
So I'm also, I guess I'm late to introducing our guest expert, Helen Hanson, who you just heard from. So Helen is a NIHR senior investigator fellowship at the Exeter NIHR Biomedical Research Center. She's a consultant in clinical genetics at the Peninsula Regional Genetics Service at the Royal Devon University Healthcare NHS Foundation Trust. Helen is also the co-lead of our recent ACMG paper that we talked about. She's a friend and colleague, and I think all of you are gonna enjoy her presentation. And then, we really appreciate all the feedback that she provides us on these cases. So Helen, take it away.
Thank you very much, and thank you for the nice introduction. So, as Troy said, we've recently had a ACMG international group thinking about a clinical practice resource for RAD51C, D, and BRIP1, so the moderate risk ovarian cancer predisposition genes. And so much of what I talk about today is from literature that we've been reviewed and synthesizing into that clinical practice resource. And yes, very good timing, as it was published, I think, yesterday. So please do have a look at that. So I'll give a bit of background, and then we'll talk about the cancer risks and our current understanding of the cancers currently associated with RAD51C, D, and BRIP1, and then talk a bit about the different clinical management recommendations and some of the challenges as well. And then I think we'll go back to quite a few cases to go through. So in terms of these genes, so they were initially really discovered, at least BRIP1 and RAD51C, in the context of Fanconi anemia. Really, BRIP1 was the first discovered in the context of Fanconi anemia, closely followed by RAD51C, but at present there's no known association of RAD51D with Fanconi anemia. And as I'm sure you're aware, they all act in the same pathway. And so in some ways, this was not a surprising finding. But after the discovery in Fanconi, then there's been quite a lot of back and forth over the years about the cancers that some of these genes are associated with. So RAD51C and D were first identified in hereditary breast and ovarian cancer families. So the initial study in 2010 looked at 480 families with cases of both breast and ovarian cancer and identified 6 RAD51C carriers. And there was not any RAD51C carriers identified in breast-only families, but the assumption was made that this was another breast and ovarian cancer predisposition gene like BRCA1 and BRCA2. But then subsequent studies from different groups who also looked at large numbers of hereditary breast and ovarian cancer families compared to controls, suggested that actually the association was really for ovarian cancer, and that RAD51C should be considered as an ovarian cancer predisposition gene and not a breast cancer predisposition gene. So this was a similar story for RAD51D, where again, families with cases of both breast and ovarian cancer were looked at, and the association was found principally for ovarian cancer in these families rather than families with just breast cancer. And then this study in 2015 by Song et al., which was again another case control study looking at unselected ovarian cancer cases, so not not known to have strong family histories. This confirmed again that RAD51C and D were moderate risk ovarian cancer predisposition genes associated with moderate cancer risks and identified in a relatively small number of ovarian cancer cases, but collectively accounting for a reasonable proportion of BRCA1 and BRCA2 negative families. And they estimated that overall the risks, were a level at which risk reducing interventions would be recommended. But then, so for a while, it was felt that really the strong association was for ovarian cancer. But then in 2020, there was a study, which is an international study across a large number of countries and centres, where they collected families known to have RAD51C and RAD51D. So there was 154 families with RAD51C pathogenic variants and 65 families with RAD51D pathogenic variants. And then, and this study did show that in these families, there was a increased risk of breast cancer, which would be consistent with a moderate risk breast cancer predisposition gene. So you can see here from these charts on the left-hand side that the red line is showing the cumulative risk for RAD51C carriers in the top part and RAD51D carriers in the lower part of the chart. And so a more approximately twofold risk compared to the population for breast cancer, and also re-emphasizing that association with ovarian cancer. And then the large study by Dorling in 2021, again demonstrated that RAD51C and D were associated with breast cancer, but specifically ER negative or triple negative subtypes of breast cancer, with an odds ratio of just below 2 for both of these genes. And so really suggesting that RAD51C and D are associated both with ovarian and also breast cancer. And this is a more recent study which was undertaken by Claire Turnbull's group, which was a meta-analysis looking at data from the Bridges study, carrier study, and also UK Biobank. And this shows, again, that there is an association with breast cancer, but probably when all of these studies are combined, slightly lower odds ratio of 1.53 for RAD51C and RAD51D for breast cancer. So a lower level of risk than other moderate risk genes such as ATM, BARD1 and CHEK2. And there does seem to be that association more with the ER negative or triple negative subtypes. So conversely, for BRIP1, after the discovery of association with Fanconi anemia, BRIP1 was initially described as a breast cancer predisposition gene. Back in 2006, this paper from the ICARE suggested BRIP1 was a breast cancer predisposition gene, but then subsequent studies refuted that and suggested that there wasn't a strong association. So this is a paper by Doug Easton's group. And then again, in the Dorling paper, which was a very large study, they showed that there was a very weak association of BRIP1 with breast cancer. So the odds ratio was 1.1, and suggesting that BRIP1 is not strongly associated with breast cancer predisposition. However, BRIP1 is strongly associated with ovarian cancer predisposition, and this study from Susan Ramus from I think 2005 demonstrated that BRIP1 was associated with ovarian cancer predisposition and accounted for a slightly higher number of cases than RAD51C and D. So in unselected ovarian cancer cases, there was about 1% prevalence of BRIP1, and the average age of diagnosis was typically in BRIP1 carriers 60s. And again, similar to RAD51C and D, the subtype was typically high-grade serous, as we see for other genes such as BRCA1 and BRCA2. And then more recently, this study from Gareth Evans' group in Manchester sort of conclusively demonstrated that BRIP1 is the third most important ovarian cancer predisposition gene after BRCA1 and BRCA2. And so they looked at nearly 3,000 unselected ovarian cancer cases, and some of these, or 15%, as we would expect, would have a pathogenic variant in BRCA1 and 2, but then when they looked at the remaining cases, just over 1% had a pathogenic variant in BRIP1, so a higher proportion compared to PALB2, RAD51C and RAD51D. And they calculated a lifetime ovarian cancer risk of around 7 to 10% for BRIP1 carriers. And again, you can see here there's this association with a high-grade serous ovarian cancer for BRIP1 carriers, as well as for other genes, and really not any association with low-grade serous ovarian cancer. So to summarize that, so what we currently understand is that germline pathogenic variants in RAD51C, D and BRIP1 are associated with an actionable ovarian cancer risk. Germline pathogenic variants in RAD51C and D are associated with breast cancer predisposition, but clinical actionability probably does depend on additional modifying factors. And I haven't gone through any of the sort of studies, but there's not any evidence at the moment to support a clear association for any other cancers. So in terms of what we do in clinical practice, so there is some published guidance, and we had some guidance published in the UK a few years ago, and then we've also more recently had an update to our NICE guidance. In the US, there's your NCCN guidance, but then we felt it would be really helpful to have an international clinical practice resource. And so similar to other genes such as PALB2 and CHEK2 and ATM, we convened an international work group to think about the current literature for RAD51C, D and BRIP1 and what we would recommend in clinical practice. And I think I would emphasize that throughout all of these guidance, there's a real emphasis on the importance of considering individualized risk for these patients. So what things are important? So firstly, how was the individual identified to have the likely pathogenic or pathogenic variant? Do they already have a diagnosis of cancer? What is the relevant family history? Is this an incidental finding, as we saw in Brenda's case earlier? What are the other modifying factors? Are there any hormonal or lifestyle factors? And also, when thinking about what recommendations we're making, what is the context? What do we need to consider? What are the competing risks from a medical perspective? And also, where is a woman at that point in her life in terms of reproductive options, and also menopausal symptoms as well. So ovarian cancer risk management. So this is the chart that I mentioned before. So this is a paper from a few years ago in JCO, which was using a 3 to 4% threshold for risk reducing salpingo-oophorectomy. And at that level of risk, really all BRIP1, RAD51C and RAD51D carriers are likely to fall above that threshold of risk. If you're using a 5% threshold, which is what we currently use in the UK based on our guidance, then you can see that at that 5% level of risk, you're just, some of those BRIP1, RAD51C and D carriers are probably straddling that 5% threshold. And these are likely to be people who have, not strong family histories of ovarian cancer. As well as considering lifetime risks, the age-related risks are really important. So again, this is the paper that I mentioned, which is looking at carriers identified through multi-gene panel testing. Looking at that, then we can see for BRIP1, RAD51C and RAD51D carriers, the median age of onset is close to 60 or above 60. So for BRIP1 carriers, the median age is 65, RAD51C 62 and RAD51D 57, which is higher than you see in cases ascertained through multi-gene panels for BRCA1 and BRCA2, and more comparable with patients who don't have pathogenic variants. So we can see that when you're ascertaining patients through this route, the age of onset is typically older than we may see if they're ascertained through family histories, strong family histories of ovarian cancer. Also of importance, the risk is clearly affected by family history. So this is the Yang et al. Paper, which was the study looking at specifically at families with RAD51, 51D and C pathogenic variants, and you can see if there's no family history, ovarian cancer risk is around 11 to 13% for RAD51C and D. But once you start having a significant family history, then that risk significantly increases up to 30% or higher. So family history is playing a really strong role. And then also, again, considering the combination of family history and age-related risks. So these are some figures that Antonio kindly provided for one of our UK meetings, thinking about risks, lifetime risks or risks to 50 for these moderate risk gene carriers. So you can see here on the left-hand side, for somebody who's a carrier from an unselected family history, their ovarian cancer risk to age 50 is 1% or less, whereas if you're considering somebody who we know has a mother who's been affected with ovarian cancer age 50, the lifetime risk is much higher, and also the risk before 50 is also slightly higher, about 2% risk, depending on the gene. So this is a quick summary. It's a bit busy, so I don't expect you to sort of read it all, but essentially all of these guidance say very similar things in that in this group of patients, so carriers of RAD51C, D or BRIP1, we wouldn't be recommending ovarian cancer surveillance in this group, and that risk reducing salpingo-oophorectomy should be discussed with women. Typically, the age is slightly variable between the guidance, but typically around the age of 50, but taking into consideration the woman herself, any menopausal symptoms she has, and also importantly the family history as well. So to summarize, for ovarian cancer genes, moderately penetrant ovarian cancer genes confer lifetime risks, which in most cases do justify risk reducing salpingo-oophorectomy, but typically close to the age of menopause. But in some circumstances, age-related risk might justify undertaking that surgery at an earlier age. So then to go through breast cancer management. So as I've mentioned, RAD51C and D are considered to be associated with an increased risk of breast cancer, but not BRIP1. They're predominantly associated with moderate breast cancer risks and primarily ER negative or triple negative. And from the Yang et al. Paper, they were sort of firmly in that moderate risk gene category with a lifetime risk of around 20% for both genes. Again, importantly, family history plays a role, and you can see from the same paper that the risk is significantly modified by family history. So here, if a RAD51C or D carrier has a mother who's affected at a young age, the risk increases to above 30%. And if they have two first-degree relatives, the risk is increasing to above 40%. So really significantly increased risks when there's a strong family history. And this is just demonstrating, again, the importance of thinking about that individualized risk assessment. So this is taken from the Bodicea or CanRisk paper from a few years ago. And this is looking at when you start to add in more modifying factors into that risk assessment, how the discrimination of lifetime risk becomes greater the more factors that you add in. So here on the left-hand side, this is for a 20-year-old RAD51C carrier, and we would estimate that her lifetime risk is about 20%. That's the vertical brown line in the middle. But then once we start to add in additional risk factors such as questionnaire-based factors, mammographic density and PRS, then you can start to see that the curve widens out with better discrimination of that risk. And when you look at the blue curve, which is including all questionnaire-based risk factors, mammographic density and PRS scores, you can see that there the range is really from about 5% to 60% lifetime risk. And in that situation, you would have, if you were including all of those risk factors, you'd have about 19% of people falling into a lifetime risk of above 30%, about 43% in a sort of moderate risk range of 17 to 30%, and 38% of women falling at a more population-based level based on our UK NICE thresholds. And similarly, if you were looking at a RAD51C carrier who had a family history, again, you see this greater discrimination of risk, the more risk factors that are integrated in the model. So you can see the range is now up to 70%, with 43% of people falling into that high risk category of above 30% lifetime risk. So again, for breast cancer, all of the guidance that's available is relatively similar in that we would suggest that breast cancer surveillance is based on individualized risk assessments. Most carriers will fall at a level at which we would recommend some additional breast surveillance depending on country-specific guidelines, but it wouldn't be routine to offer risk-reducing mastectomy, but it may be relevant for small numbers of families who do have those additional risk factors, such as very strong family histories. So just to summarize that, so individualized risk assessment is important, surveillance according to thresholds used in your countries, and then also, risk reducing mastectomy probably only relevant to a small number of patients and families. So coming back to some of the challenges of counselling in these families, so we at the moment identify most of these patients through targeted testing or multi-gene panel testing, but the challenges in counselling are these evolving estimates of cancer risks and also the differences in thinking about individualised risk and what factors can be utilised in a risk assessment model. So typically PRS and mammographic density aren't routinely measured at the current time. Also, the importance of thinking about a negative targeted test for a familial variant that still requires some consideration of whether that patient still has an increased risk of breast or ovarian cancer. And then also, as mentioned before, the possibility of biallelic inheritance and Fanconi. And so we do recommend in our ACMG guidance that counselling should be undertaken by a genetics healthcare professional who is familiar with these different challenges. At present, there is not any therapeutic implication, so knowledge of BRIP1, RAD51C or D status doesn't guide any specific targeted treatment, but there are ongoing studies in this area. So take-home messages are really that individualized risk is important. Clinical management recommendations may evolve in the future, particularly as integration of modifying factors becomes more routine in breast cancer risk assessment, and also when there may be more therapeutic options available in the future. So just again to highlight the ACMG paper, which is, I think the link has been shared, and the people involved in that group, particularly Joanne, who is a co-chair of that group, and JB, who's the trainee on the group, who helped pull the document together, and also to Mark, who I've specifically highlighted because a number of these slides are taken from one of his talks that he was happy to share. So thank you very much.
Thanks, Helen. That was excellent. You know what I'm going to do? I don't see any questions in the chat. If anyone does have any specific questions for Helen, please ask away. Again, I think the cases, we have quite a few cases. We'll get through as many as we get through, but they may also bring up some points of discussion as well. So I will move along. Oh, the one thing I was going to say is I liked how you weaved in ascertainment. I know Doug Stewart, who is also part of that group, is on the call, and you know it is so important to like look at the risks in the context of how they were ascertained, and as you mentioned, or as like in Brenda's case, it was an incidental finding. So the risks aren't necessarily going to be the same. But even from a population-based ascertainment versus a clinic-based ascertainment, like we don't necessarily have a way of factoring that in other than, I guess, family history, which would be kind of a surrogate personal and family history. But it's all very interesting how this, you know, individualized risk assessment is going to work, which we are all pushing for, but the implementation piece will, again, be a learning curve for all of us. We do have one question, Helen. Any differences between truncating versus non-truncating variants?
So there's less evidence for this when you look at compared to say ATM or CHEK2. But I think if I go back to one of the slides from the meta-analysis, there was a slight difference. Can I go back to that slide? A very slight difference. No, it's probably a bit earlier, where there was a difference demonstrated for breast cancer. I think I'm nearly there, sorry. So here from this meta-analysis here, where they looked at RAD51C and D, there is a very slight difference in truncating variants compared to when truncating variants and non-truncating variants. So you can see that there's a slight difference for RAD51C, but RAD51D not so much. So I think it's difficult to say. I think there's a bit less evidence than there is for the other moderate risk genes. And certainly I think in our ACMG paper, there is only a very small number of missense variants that have been classified or non as pathogenic on ClinVar. So there seems to be less missense variants than maybe for other moderate risk genes.
Couple other questions. Brenda asks about PRS. Are you guys, I know in the US we're not at this point typically doing it, but what are you guys doing there?
Yeah, so at the moment we're not using it, but there's been lots of discussion of it. There's been a research study which is two different research studies that are being run by Mark Tishkovitz, which are looking inclusion of PRS in either patients having predictive testing for known familial variants or in people with strong family histories of breast cancer. So those are two research studies looking at how much impact it makes on a risk assessment, and thinking also about how we'd integrate that into routine clinical practice, but it's not being routinely undertaken at the moment in the UK, so very similar to US.
And then another question, are there specific variants in any of these genes associated with certain ancestry affiliations?
So I can't remember off the top of my head, but there are some founder variants. So there is, again, in the paper in the ACMG supplementary information, we've got a list of potential founder variants. So there are some variants that are particularly associated with specific ancestries.
Okay. We will go on to our case, and I'm sure there will be more questions, but our next case, it's actually my colleague Katie Lang's case, but she's not able to be here. She's at CGA, where many of our other usual participants may also be, our healthcare partners. But here is the case. I'll do my best to do this justice, but this was a patient, proband is right here, diagnosed with ADH, atypical ductal hyperplasia, and was considering risk-reducing mastectomy. And subsequently, the breast surgeon ordered germline testing. So you see here, here's a proband. She's got two family members, mother and aunt, with ovarian cancer. And then there's also a breast cancer here, as well as a pancreatic cancer. And she was found to have a RAD51C mutation, not mutation, sorry, variant of uncertain significance. So at the time this was reported out, it was a RAD51C VUS, and it wasn't even conflicting. It was a straight VUS by all labs that had put this into ClinVar. Since there was only one living sibling in her mother's generation, Katie recommended she consider testing. So she spoke to her aunt, Aunt M, and she agreed to an appointment. M also carried the VUS and no other pathogenic variants. At the time, this was still listed as a straight VUS in ClinVar. So in January of 2025, there was an amended report for M, so the original proband, with upgraded RAD51C variant. So it is now considered likely pathogenic, which does track with the family history, right? So again, Katie reached out to let the original proband know about this upgraded result. And since that time, you can see that multiple family members have also been tested, including this aunt who was positive, both of her daughters. Granddaughters had actually, right here, had been tested elsewhere. And they were negative, but not surprisingly, their mother was also negative. So again, we thought this was an interesting case with the evolution of testing and our knowledge, and really a VUS result, even with this kind of concerning family history. It's nice that the labs reach out to us for updated interpretations, but this would be the kind of family that we should already kind of be keeping an eye on, or asking them to follow up with us every few years to consider any sort of updated testing. I don't know what to make of this breast cancer at age 45. You're going to see breast cancer smattered through many of the pedigrees we present. And Helen, I completely agree with you that the data that we have, the published data, doesn't support a breast cancer association. I don't know if in your practice you tend to see some of these breast cancers, and I don't know if it's just sporadic cases in a family with these mutations, but there are certain families where you see like the breast and ovarian cancer phenotype. I wouldn't say all of them, but sometimes we tend to see them, but would welcome your thoughts.
Yes, so do we know if that breast cancer was ER negative or triple negative? Because this one's RAD51C, isn't it? So we
Yeah,
do
so you'd expect a triple
triple
negative. We
negative,
don't
yeah.
know
We don't know,
because
yeah.
we don't have the path report. But yeah, you're right. That would give us a little bit more of a clue.
Mm-hmm.
But that's neither here nor there, I guess. Like
No.
right now, our data is not telling us this, that there is a substantial association or a clinically meaningful association.
Yeah, I think so. I think for RAD51C, we do recognize that there is an association, but
Oh, I'm
it's kind of
sorry. I was
yes,
thinking BRIP1. Yeah,
the
I was
one, yeah.
thinking BRIP1. Sorry. Right. Yeah, of
That's
course.
okay.
RAD51C.
But
There is an association.
but still not so I guess it maybe we can suppose that it is more likely that she had an ER negative cancer. I noticed there's a pancreatic cancer, and again,
That
there's
was
been,
the
I
other
think,
thing. Yeah. I
there's
was going
been
to ask you
some
about.
suggestion of, is there an association with pancreatic cancer? But I think it's about from the current evidence, there's not clear evidence of an association with pancreatic cancer at the current time. Do you know why it was reclassified, this one, as likely pathogenic? Was there an explanation for the upgrade or?
I mean, more data is my understanding,
Mhm,
but I don't know. I know it was a bit of a surprise
mhm,
when it was upgraded because there was like the system actually worked the way it's supposed to with, recommendations for medical re-review
mhm,
periodically.
mhm,
So that's kind of how this came to attention.
mhm. Yeah.
I do see something from Doug regarding the founder variant question, supplemental table 2 in our paper lists proposed variants in Newfoundland, Finnish, French Canadian, Chinese, Japanese, Inuit, and Icelandic cohorts. So that was news
Thank you,
to
Doug.
me, but it is, yeah,
I
it's
couldn't
in the
remember all the
paper.
different ones off the top of my head. Yeah. So thank you, Doug, for putting that in.
Yeah, and cascading, yeah, that is the plan. Katie has been trying to get as many family members in as possible, so. Okay. Um, Next case, back to Brenda. Take it away.
All right, thank you. And I was reading on ClinVar about that RAD51C variant, and the only thing I can see is functional studies suggest that it disrupts a region of the protein that's causative for disease.
Is it conflicting interpretation,
It
Brenda?
is. It still is. Yeah, Ambry. Well, according to ClinVar, Ambry still has it as VUS, but it was last updated in May. And we know that there is sometimes a delay between their classification and ClinVar.
Right. And this one makes sense. The family history really makes sense that this was a
Mhm.
positive, but yeah, it makes
Yeah.
sense that it's conflicting right now until
Mhm.
people figure out what to do.
Yeah. All right. Okay, so I saw this patient actually in this family in 2023. So I first saw a mom here who's 66, had breast cancer at 65. She had triple negative breast cancer, and had a multi-gene panel. She was positive for RAD51D, likely pathogenic variant. And so I saw her daughter, 37-year-old, and she also happened to test positive for that RAD51D, likely pathogenic variant. The mother had a total abdominal hysterectomy and bilateral subinguinal I don't remember why, but she had one earlier. So ovaries were gone, family history of uterine cancer, and two relatives in breast cancer, and then no other family history. Um, what's important, or what's interesting, I went back to refresh my memory on this case, and the 66-year-old, she's still being followed for breast cancer, for her breast cancer. And so they did Tempest testing XT, tumor NGS, and they provided a blood sample, a match, a normal match, and that RAD51D pathogenic variant was not reported because it's a relatively large deletion. And so it's important to keep that in mind, that if they had only done the XT, they wouldn't have found the RAD51D mutation. And so I guess I don't think there's another slide. So RAD51D associated with breast cancer and ovarian cancer, the risks 20 to 40% for breast cancer, 10 to 20% for ovarian cancer. There is no family history of ovarian cancer. And so when I ran her ovarian cancer risk was only 3.2%. And so I think what I worry about these cases is when we provide these risk estimates, it is recommended to have a bilateral slumping oophorectomy per guidelines. This patient was actually difficult to get into the visit. She did not show up to her result disclosure appointment, so I called her multiple times. When I recommended to see a gynecologic oncologist, she declined an appointment and she said she was going to talk to her primary care. And so I wonder if this risk had anything to do with her not feeling quite as upset or concerned about her risk. And so sometimes I do worry about how I present this information. Am I presenting it? Should I be more reassuring? Should I be more, obviously the guidelines are the guidelines, but there's risk. I can see how someone compared to the general population would not see as a high enough risk to move forward with that risk reducing surgery.
Yeah, I think this is similar to your other case where the risk is falling at the really lower end of the range, likely because of the absence of a very strong family history. But I know I was going to ask, I know somebody's put it in the comments, is there any possibility that the grandmother or the great aunt had ovarian cancer rather than uterine cancer? Do you have any confirmation of that? So
That's a good, yeah, that's a good
Mhm.
question. I don't think so. I think that we just know whatever they were told.
Yeah.
I would say it's unlikely though, don't you guys think? Because ovarian cancer is usually like stomach cancer, ovarian cancer get mixed up, but uterine cancer, like you have abnormal bleeding, you don't generally pass away from it. And when you look at it, she was diagnosed at age 45, died at age 83. So the uterine cancer seems probable in my
I,
mind, just based on the history, right?
I mean, at least in that relative. Now, could it be
yeah.
cervical cancer? A lot of people also confuse it with
Well,
that
yeah,
cancer.
well, that too. Cervical uterine, but usually uterine ovary are not as confused, I guess. I don't know. Just because uterine is diagnosed at an early stage for the most part, and ovary is not.
Yeah, I agree that if she was diagnosed at 45, it seems, and then lived until 83, it's probably unlikely ovarian. But because we in the UK have the cancer registry, so we can often obtain quite a lot of these cancer confirmation. It is surprising how mixed up diagnoses get for any gynecological cancer, so cervical, ovarian, uterine. Somebody has added in the comments, which I think is a good point, about if the treatment for her uterine was actually having BSO as part of her treatment, then she has reduced her risk, and so actually, yeah, I think that's a good point. So I think, although the CAN risk is estimating a lower end of that range of risk, there are some factors which could actually push her risk higher if actually that grandmother had a BSO, or if that aunt had an ovarian rather than a uterine cancer. So
Yeah,
yes, I agree. I think I'd be cautious. I think her risk is probably at the lower end of that risk, but I think I would still be cautious that she's not come forward for her results appointment and had more discussion about her risk.
so the other question here for Tempus XT, not able to detect the large RAD51D deletion, isn't Tempus using Ambry? Here's my understanding. If you do XG through Tempus, they use Ambry, but if you do XT, they're running their regular platform, like
Yeah,
Brenda had explained.
XT it's not a full germline test. It will detect some mutations, but a negative result is not, it should not, yeah, XT is different than XG. XG is the germline through Embry. XT is not. XT will miss some del dupes, and not every gene is on the list of germline on XT.
Okay, and I see some other questions regarding founder variants in these genes in the FC of Quebec. There are 2 papers by Drs. Folks and Tonin groups, one founder variant in RAD51D, another recurrent possible founder in RAD51C. Maybe we didn't get to those for our ACMG paper, but again, good to be aware of. Would we provide CAN-RISC estimates for ovarian cancer and breast cancer if family history is predominantly male? I would say yes, because I think that, again, we had a session previously with Dr. Antonio, and he mentioned the importance of putting in the family structure. So looking at males, females, expanding out the family history as much as you have, because again, we give estimates based on personal history if we don't have family history. You just have to, I guess, mention to the patient that these are estimates based on the information we have. And when you have mostly male members, you're just not going to have as precise of an estimate. I don't know, Helen, do you have
No,
thoughts on that?
yeah, so we would still use CAN-RISC and calculate the risk. I think in the model there is, it would account for some of that, but I think we have to be cautious when we're using CAN-RISC. It is I think the best available model we have, but I think we have to use our clinical judgment as well, and also remember that when we're using that CAN-RISC model, we're not integrating all of those other factors at the moment, like PRS, mammographic density, so it's not completely perfect. So sometimes it can give this illusion of certainty because it's giving us these risk figures, but it isn't. It is at the end of the day only a model, and based on the the currently available information, and certainly that might evolve in the future.
Okay, I'm going to do just one more case. I'm going to skip over the next case, and one of my colleagues, Mariah Hubert, I'm going to see if Mariah is available to do the last case, which I think again is super interesting. Mariah, take it away.
Okay, thank you. All right, so this is a patient that I saw due to her history of renal cell cancer, diagnosed at age 40. So there was a concern due to her early onset renal cell cancer. But she also had this family history of multiple paternal relatives with early onset breast cancer and 2 paternal relatives with ovarian cancer. Unfortunately for one aunt, we knew she had ovarian cancer, but we don't know what age she was diagnosed. And then for her grandmother, she was diagnosed in her 50s, but the patient mentioned that she passed away due to other causes. So we did a large multi-gene panel on her, and she was identified to have a BRIP1 mutation, which could potentially, we think, explain the ovarian cancer in the family. But like Dr. Hanson talked about earlier, we're not seeing an association with BRIP1 and breast cancer in the research, but we're certainly seeing it anecdotally in our patients with a BRIP1 mutation. So we have 3 relatives on this side of the family. It's pretty striking with early onset breast cancer. So the big caveat in all of this is that no family members have been tested. So we have not even confirmed that it's coming from father's side of the family or the mutation status of any of these individuals. But we just thought this was an interesting case and somewhat of an incidental finding, given her main referral purpose was the renal cell carcinoma, but certainly not fully incidental given the family history.
Thank you. I looked at this case before, and I think my initial thought was it would be obviously great to have information, have a test on one of those family members on the paternal side of the family, and know what the results were from a the breast cancer predisposition panel in one of those relatives. So it would, yeah, I think that would be really helpful. And I don't know if there's any more people on that side of the family who could be tested, or if you ever arrange testing on tissue samples, because I think that would be interesting to know if they did have another predisposition, or if they do have that BRIP1 variant. I've not there's certainly not any suggested association with renal cancer, but what type of renal cancer did she have? What was the pathology for that?
I can't remember off the top of my
No.
head.
Okay.
Mm-mm.
No.
Oh, Tua, you're muted.
So I'm just going to show this case because I know we're at time, but it highlights what Helen just said. So like just being able to track it through the family. So this breast cancer risk, we don't know what's going on, right? But here's a family where a 54-year-old female, triple negative breast cancer, she's BRIP1. And she's got a strong history of breast cancer in the family. Both sisters are negative for BRIP1. But then her mother and her mother's twin are positive, or her mother is positive for BRIP1, presumably, yes, and her twin as well, because the son is positive. So, like, even tracking it through the family, you're right. Like, sometimes we're seeing this, we don't know, but just because we're seeing these early onsets doesn't mean it's BRIP1. So, I do think anecdotally, I've seen it as well. Helen, I don't know if you've seen it, but I think we need to delve deeper whenever we can to kind of clarify it. And so I don't know what's going on. Like, are there specific variants that could predispose to breast cancer? Maybe, but I don't think we know that at this point. So we can't say that BRIP1 is associated with breast cancer based on the information we have. And I think this pedigree, that's why I just wanted to show it real quickly, kind of hits that point home. Just because you're seeing early onset breast cancer doesn't mean it's BRIP1.
Yeah, I think that's a really nice example, because you would have looked at that and thought, oh goodness, how come BRIP1 isn't associated with breast cancer? Look at this pedigree, but actually, it very clearly demonstrates they don't have the BRIP1 variant. So, yes,
Yeah,
I
no,
think,
which is
it's a very great example.
okay. So I apologize. We are a few minutes over. Just we're excited about our upcoming case conferences. In November, we have Dr. Payal Kinsha talking about Lee-Fraumeni syndrome and the metformin trial and other updates. So there is a trial that's being run through the National Cancer Institute. And then in December of this year, we have Dr. Raymond Kim from Toronto, who will be talking about liquid biopsy and early diagnosis of hereditary cancers. So again, certain topics that are very relevant to many of us because we see patients and are dealing with these kinds of issues. So big thank you to Helen. Excellent talk. We all learned a lot and we appreciate your guidance and insight. Thanks to all of our attendees, and we'll be in touch soon. Thank you.